Hello everybody, my name is Robert McCabe and I'm a neurosurgery resident out of Ascension Providence Hospital from Michigan State University. My research is over safety and efficacy of bicortical pedicle screw instrumentation in the lumbar fusion. Okay, this is a controlled cohort study of 521 patients and it was done at a single institution. I have no financial disclosures or conflicts of interest. Pedicle screw instrumentation and fusion is a very common treatment for multiple spinal conditions. Biomechanical studies with bicortical screw placement have shown better pull-out strength and overall increased mechanical strength. However, safety and efficacy data on this technique are lacking at this time. So our objective was to demonstrate that bicortical screws, when compared to non-bicortical screw instrumentation, provide similar perioperative complication and fusion rates for lumbosacral fusion. So what exactly is bicortical pedicle screw technique? The image here on the left shows an axial X-ray showing the position of a mid-body screw as well as a bicortical pedicle screw on the left. Bicortical means that the screw enters all the way through the pedicle, breaches the posterior cortex of the vertebral body, and then advances all the way through the cancellous portion of the bone into the anterior portion of the vertebral body, traversing two cortices. Studies have shown that traversing through both cortices in the vertebral body have increased pull-out strength as well as overall stability. However, it's not without its risks. The main risks associated with bicortical pedicle screw placement are in direct relation to the anatomy of the great vessels that sit immediately anterior to the vertebra. The image on the right shows the close proximity of the aorta as well as the inferior vena cava. Not shown in this image, we also have some of the great iliac nerves that are also at risk when placing bicortical pedicle screws. This is a retrospective chart as well as OR report and registry review. All cases were elective, minimally invasive, as well as open lumbosacral fusions between January 2014 and September of 2015. A bicortical segment was defined as an interspace with two bicortical screws in each the upper and the lower adjoining vertebra for a total of 4 bicortical screws spanning one disc space. Fusion criteria was evaluated in a standardized fashion, and these included the Such X-ray criteria as well as the Christensen CT method. Bicortical screw complications that were evaluated included accidental intraoperative puncture or laceration of an artery or vein, prevertebral hematoma, venous thrombosis, and pulmonary embolism due to the dynamics of the blood flow through the vena cava if there was any accidental breach. Univariate statistics and multivariate logistic regression were used for data analysis. Patient demographics identified included age, BMI, sex, whether the patient was diabetic, steroid use within 2 weeks preoperative, smoking, as well as osteoporosis. Fusion outcome and complications. As far as complications, there were no complications directly attributed to the bicortical technique that were noted. Fusion outcomes between the bicortical and non-bicortical segments were not statistically significantly different. In conclusion, we were able to show that bicortical screw instrumentation did not lead to increased risk of operative complications. We were also able to find comparable fusion rates as non-bicortical screw instrumentation in the lumbosacral fusion. However, we will need a larger sample size to show a superior fusion rate with bicortical screw instrumentation. Thank you very much.